So imagine a child suffers a severe head injury. They recover physically, right? But then months later, their entire personality just seems to have fractured.
Yeah.
They become aggressive, wildly impulsive, completely disinhibited. And for decades, the prevailing thought in general medicine was to classify this as just a psychological reaction to
With
trauma.
secondary behavioral disorder.
Exactly. But what if the physical breaks in their frontal lobe, I mean, the actual white matter tracks required for emotional regulation, have simply been sheared apart?
It forces a complete paradigm shift, doesn't it? I mean, in how we approach the diagnosis, we have to stop looking for a psychological root cause and start addressing a structural neurobiological deficit.
Because it's a physical breakdown.
Absolutely. We are dealing with altered hardware here, not just a software glitch.
And that fundamentally changes the entire diagnostic landscape. You see, in adult neurology, an injury is like damage to a finished building. You know, a broken window, a collapsed roof. The damage is discrete.
Spot on. The structure is already there.
Right. But step into the world of child neuropsychiatry, and we are looking at an active construction site. An insult to a child's brain happens while the walls are literally still going up. The foundation is actively being poured. So the blueprint itself might be altered, or the structural scaffolding gets compromised.
Which means the entire developmental trajectory shifts.
Right.
And, well, that is the essential framework for today. If we define psychiatry for this discussion, it is the study of how the brain, the mind, and experience interact. And critically, how that process can go wrong.
Yes.
In pediatric populations, this interaction happens at warp speed. An early disturbance doesn't just damage what is already there, it alters what that brain is capable of building tomorrow.
That's beautifully put. And today, we are taking a deep dive into the psychiatric aspects of child neurology. We're specifically mapping out the conceptual models from Kaplan and Sadok's Comprehensive Textbook of Psychiatry, Chapter 2.13.
It's a dense chapter, but so crucial.
Oh, incredibly dense. But our mission today isn't to just regurgitate textbook facts. We want to build robust mental models for you. We'll dissect 4 distinct neurological conditions: fetal alcohol spectrum disorders, prematurity, epilepsy, and traumatic brain injury.
All to uncover exactly how these early disturbances layer onto a system that is still forming.
Right. And throughout this exploration, there's a core clinical imperative we want you to keep in mind. In child neuropsychiatry, clinicians are not merely assessing what is, they must assess what is becoming.
Yes, you have to evaluate the moving target of neurodevelopment. It's never static.
So let's begin with the altered blueprint, which is fetal alcohol spectrum disorders, or FASD. Here we are looking at the functional fallout of a highly potent behavioral and physical teratogen.
A teratogen that is unfortunately quite common.
Extremely common. Alcohol exposure in utero doesn't just cause localized damage, it radically rewires the neurodevelopmental trajectory. The U.S. prevalence sits between, 1.1% and 5.0%?
Yeah, around there. Which makes it a staggeringly common presentation in child psychiatry.
It really is.
It's ubiquitous, yet frequently misunderstood by clinicians. The diagnostic architecture actually relies on 5 critical domains. So you've got documentation of prenatal alcohol exposure, obviously, then a characteristic pattern of minor facial anomalies, growth deficiency, deficient brain growth, or abnormal morphogenesis.
And the 5th being severe neurobehavioral impairment, right?
Exactly. And the specific configuration of these domains really dictates where a child falls on the FASD spectrum.
Let's talk about those facial anomalies for a second, because they are highly specific, aren't they? We are looking at palpebral fissures at or below the 10th percentile, a thin vermilion border, and a smooth philtrum.
Yes, the classic triad.
But those aren't just random aesthetic changes, are they? If we look at the embryology, alcohol disrupts the migration of neural crest cells during the first trimester.
The very same cells responsible for forming the frontonasal prominence.
Exactly. So the facial dysmorphology is actually a visible external marker of midline brain disruption that's happening simultaneously.
That's a brilliant way to frame it. The face predicts the brain because they share that exact embryonic origin. But, this heavy reliance on the classical physical phenotype created a massive historical blind spot in our field.
How so?
Well, for decades, clinicians focused primarily on the severe end of the spectrum fetal alcohol syndrome, or FAS, which mandates those facial features and growth deficits. Consequently, an enormous cohort of children who suffered profound neurobehavioral and cognitive damage from prenatal alcohol exposure.
Well, but just lacked the distinct facial anomalies.
Yes, they were entirely missed.
Wow, so they were just labeled as having severe, intractable behavioral problems without any actual etiologic context.
Precisely. And this is where the proposed DSM-5 diagnosis of neurobehavioral disorder associated with prenatal alcohol exposure, or NDPAE, becomes an absolute game changer.
Right, NDPAE, it fills that critical diagnostic void.
It officially recognizes that prenatal alcohol exposure causes devastating cognitive and behavioral fallout entirely independent of the physical markers. It validates the invisible neurological damage.
Which is huge for these families. To meet the criteria, there must be evidence of more than minimal prenatal alcohol exposure, coupled with childhood onset impairments in neurocognition, self-regulation, and adaptive functioning.
Yeah. And let's drill down into that cognitive fallout, because the profile is highly specific. For example, in verbal learning, the primary deficit isn't necessarily memory retention. It's actually encoding.
Oh, really? Encoding, not retention.
Yes, and understanding that mechanism fundamentally changes the intervention. If a child with FASD manages to successfully encode a piece of information, their retention is relatively intact. The structural bottleneck is in that initial processing and filing of the data.
Oh, so if a teacher assumes the child is just forgetting, they'll just use repetition.
Exactly, which is useless here. If the issue is encoding, the intervention must focus on multisensory presentation to essentially force the encoding process.
That makes so much sense. But alongside that encoding bottleneck, we see profound deficits in executive function, right? Working memory, response inhibition, and crucially, set shifting.
Yes, the set shifting is key.
But wait, here's the clinical diagnostic trap. The sources say that between 44% and 96% of kids with FASD meet criteria for comorbid ADHD.
A huge overlap.
It's massive. So if a psychiatrist evaluates an impulsive, distracted child who is failing academically, isn't it incredibly easy for them to just reflexively write this off as severe, run-of-the-mill ADHD? What is the specific clinical red flag that tells a psychiatrist, wait, this is a totally different mechanism?
That is perhaps the most vital differential diagnosis in pediatric outpatient psychiatry.
Yeah.
You have to isolate the specific nature of the attentional deficit. In idiopathic ADHD, the core deficit is sustaining focus over time.
Right. They get bored or fatigued.
Yes, the child's attention simply fatigues. But in FASD, the primary failure is in set shifting.
So if you ask them to categorize a stack of blocks by color, and then halfway through you change the rule and ask them to sort by shape.
A child with idiopathic ADHD might just lose interest. But a child with FASD literally cannot execute the cognitive pivot. The structural flexibility just isn't there.
Oh, wow. So it is cognitive rigidity rather than attentional fatigue.
Precisely. Furthermore, there is an even more definitive clinical marker, and that's the trajectory of adaptive functioning.
What do you mean by trajectory?
Well, when we look at longitudinal parent reports of everyday practical skills, things like communication, socialization, daily living children with idiopathic ADHD, despite all their struggles, generally demonstrate an upward developmental curve.
They acquire skills, just maybe slower than their peers?
Right. But children with FASD show an arrested development in socialization and communication. They hit a developmental ceiling and literally fail to improve with age.
They flatline developmentally.
Yes.
And because that comorbidity rate is so high, we frequently see both mechanisms operating simultaneously, don't we? A child with both FASD and ADHD experiences a synergistic impairment. It's far worse than the sum of its parts.
Factorial design studies confirm this vividly. When researchers isolate children with both conditions, they exhibit the absolute greatest impairment in the communication domain of adaptive behavior. And the presence of ADHD layered onto the FASD blueprint dramatically elevates the rates of conduct disorder and externalizing behaviors. You have the underlying structural rigidity of FASD combined with the impulsivity of ADHD.
That creates an incredibly volatile clinical presentation.
Highly volatile.
So we have a situation where a teratogen directly alters the biological blueprint, resulting in rigid, inflexible architecture. But what happens when the blueprint is perfectly fine, but the construction timeline is radically accelerated?
Prematurity.
Exactly. Moving from teratogenic exposure to the physical timing of birth, we enter the world of prematurity and low birth weight. Here, we are looking at highly vulnerable structural scaffolding.
The paradigm shifts completely from toxic exposure to environmental timing. 10% of U.S. children are born prematurely.
That's a huge number.
It is. And neonatal intensive care is advanced to the point where survival rates for extremely premature and very low birth weight infants are just remarkable. We're saving babies we couldn't have saved 20 years ago.
Right, but the rates of subsequent neurological and psychiatric sequelae have remained stubbornly unchanged. Extrauterine survival does not equate to typical neurodevelopment.
It doesn't. And we have to look at the glial vulnerability model to understand why. There's a highly critical window between 24 and 32 weeks gestation. The cerebral cortical volume is attempting to quadruple during this exact period.
Quadruple in 8 weeks.
Yes. And to support that explosive neuronal growth and organization, the brain relies entirely on its scaffolding, the glia.
Specifically the preoligodendrocytes, right?
Exactly. During this specific 8-week window, the dominant cell type in the developing brain is the preoligodendrocyte. These are immature glial cells that will eventually mature into the oligodendrocytes responsible for myelinating the axons.
So they're supposed to become the insulation for the brain's wiring.
Yes, but in their immature state, they're exceedingly fragile. They lack the robust antioxidant enzyme systems of mature cells, making them highly susceptible to oxidative stress, hypoxia, ischemia, and inflammation.
Which makes perfect sense. I mean, when a child is born at 26 weeks, they are violently thrust into an environment filled with those exact stressors. The ventilators, the fluctuating blood pressure, the oxygen saturation drops.
It is an absolute assault on those unprotected preoligodendrocytes.
And that initiates what Joseph Fulpe conceptualized as the encephalopathy of prematurity, which is terrifying because it's not a static injury, is it? It is a reciprocal destructive cycle.
That's right. The primary insult targets those vulnerable preoligodendrocytes, causing widespread apoptosis or cell death.
And because these glia are meant to provide structural and trophic support to developing neurons, their death triggers a secondary neuronal injury. The neurons fail to mature properly, their axonal growth is stunted, and that in turn further impairs the survival of the remaining glia.
It's a vicious cycle. The structural supports rot away, bringing the functional circuitry down with them. And this manifests anatomically in 2 primary pathways. We see intraventricular hemorrhage, or IVH, and paraventricular leukomalacia, or PVL.
Let's start with the hemorrhagic pathway. IVH originates in the subpandial germinal matrix, which is highly active in the premature brain.
Right. The germinal matrix is a dense, highly vascularized region situated just beneath the floor of the lateral ventricles. It is essentially the brain's cellular factory. It's the birthplace of neurons and glia that eventually migrate outward to form the cerebral cortex.
Okay, so let me try an analogy here. If we think of the germinal matrix as a highly volatile, high-output manufacturing plant, the capillaries supplying it are the supply lines.
Yes.
In a premature infant, these capillaries lag a mature basement membrane. So if the infant experiences sudden swings in systemic blood pressure, which happens constantly in the NICU, those fragile supply lines simply explode under the pressure. The raw materials are destroyed before they can ever be shipped out to the cortex.
That is a brilliant mechanistic analogy. And the severity of this hemorrhage is actually graded from 1 to 4. Grade 1 is confined to the matrix itself. Grade 2 breaks into the ventricles, but importantly, it doesn't enlarge them. Grade 3 acutely distends the ventricles.
And grade 4?
Grade 4 is catastrophic. The hemorrhage extends into the surrounding brain parenchyma, causing severe venous infarction, tissue necrosis, and invariably resulting in significant motor and cognitive impairment, things like spastic diplegia.
That's heartbreaking. But the other pathway, paraventricular leukomalacia, or PVL, is often described as clinically silent, isn't it? It doesn't present with the dramatic alarms of a grade 4 hemorrhage, yet it is just as devastating.
Absolutely. PDL is a non-hemorrhagic white matter injury that occurs specifically in the watershed areas of the brain.
And to understand PVL, you have to understand the vascular anatomy. The watershed zones are the regions at the extreme distal ends of the arterial blood supply, near the angles of the lateral ventricles.
Yes, they are the most vulnerable tissues when systemic blood flow drops. If a premature infant experiences ischemia, these deep white matter tracts undergo focal necrosis.
It's like pulling a cake out of the oven way too early. The structural integrity just isn't there, so the internal layers sink and collapse. But, and this is crucial, the brain is incredibly plastic. The sources mention functional MRIs showing these kids using novel neural pathways to complete tasks. So is the brain actively building detours around the necrosis?
It is. The plasticity is genuinely awe-inspiring. The brain detects the damaged watershed areas and actively builds detours around the dead tissue.
But there's a cost to that, surely.
A heavy metabolic and cognitive tax, yes. You can actually quantify the toll of these inefficient neural detours. The magnitude of the cognitive deficit is inversely correlated with gestational age. A child loses roughly 1.5 IQ points for every single week they are born prior to 33 weeks gestation.
Wow, 1.5 points per week.
Extremely premature children often score a full standard deviation below term controls on cognitive batteries. And beyond global IQ, the specific functional deficits reflect the reliance on these roundabout pathways. We see profound deficits in processing speed and working memory.
Because the electrical signals simply take longer to traverse the compensatory networks.
Exactly. It's taking the scenic route every single time you want to process a thought.
Which brings us directly to the psychiatric sequelae. When these premature children reach mid-childhood, the clinical manifestation of that altered wiring becomes glaringly apparent. They are 4 times more likely to be diagnosed with ADHD. But again, this is a mechanistically distinct form of ADHD, right?
Completely distinct. Full-term children with idiopathic ADHD frequently present with hyperactivity and impulsivity. In stark contrast, premature children overwhelmingly exhibit the inattentive subtype.
So they aren't necessarily bouncing off the walls.
No, their neurobiology isn't driving them to climb the walls.
Yeah.
Rather, their damaged white matter tracts just fail to sustain selective and divided attention. It is fundamentally an underconnectivity issue.
That distinction is so important, and the data on autism spectrum disorder in this population is equally revealing. The overall risk for ASD is 2 to 3 times higher in premature children, and it skyrockets to 8 times higher in extremely premature cohorts.
But the phenotype is fundamentally different here, too.
How so?
The presentation heavily skews towards social and pragmatic communication delays. It lacks the pronounced stereotypic repetitive motor behaviors that often characterize classic idiopathic autism.
Fascinating.
And moreover, while idiopathic autism demonstrates a strong male predominance, the risk profile in prematurity shows a striking elevation for females born at less than 33 weeks gestation.
Really? Why females?
Well, it seems the extreme physiological stress of prematurity overrides the typical genetic or hormonal protective factors that usually buffer females from ASD.
Wow. So whether by teratogen or early birth, altering the physical structure leads to highly specific psychiatric vulnerabilities. Let's move from the physical tracks to the electrical signals that run along them. Our third area of focus examines epilepsy electrical storms on a developing grid.
And it's vital we establish right away that epilepsy in childhood cannot be viewed strictly through a neurological lens as a mere motor event.
Right. It's not just the physical seizure.
Exactly.
Yeah.
It is a profound network disorder that inherently disrupts psychiatric stability.
The Connecticut cohort study is the perfect illustration of this. Researchers tracked over 500 children with new-onset epilepsy, and they stratified them into complicated and uncomplicated groups.
Yes.
The complicated group had either visible structural lesions on an MRI or an IQ below 80. Predictably, 38% of those children developed psychiatric disorders.
Which makes sense. The underlying brain damage drove both the seizures and the psychiatric symptoms.
But the true revelation is the uncomplicated cohort, right?
Right.
Children with completely normal MRIs and typical intelligence.
Yes, in that completely uncomplicated group, 27% still exhibited a comorbid psychiatric disorder.
Over a quarter. Over a quarter of children with no visible brain damage and normal cognitive function are dealing with significant psychiatric fallout.
It firmly establishes that the electrical instability itself, those microscopic network misfires causing the seizures, is deeply pathogenic to mood, anxiety, and behavioral regulation.
The electrical storm fundamentally alters the neurochemical environment, but as clinicians, we immediately hit a massive confounding variable here. If a kid is having seizures and acting out, how do we know if it's the epilepsy causing the behavior or the pills we're giving them to stop the epilepsy?
It is the ultimate clinical catch-22. We know the anti-epileptic medications carry heavy psychiatric side effect profiles. The childhood absence epilepsy trials provide an absolute masterclass in this dilemma.
Right, because absence epilepsy, which is characterized by transient lapses in consciousness, provides a clean model. It typically lacks massive structural brain lesions.
Exactly. So in a large double-blind trial comparing valproate, ethosuximide, and lamotrigine, the baseline data showed that 36% of the children already possessed attention deficits prior to receiving any medication.
Which confirms the underlying network disruption causes primary psychiatric symptoms. The grid is already struggling.
But then they intervene with medication, and the numbers shift dramatically. After roughly 16 weeks of treatment, a staggering 39% of the children on valproate exhibited severe attention deficits.
Nearly half the cohort on valproate suffered cognitive impairment, compared to, 32% on ethosuximide and 24% on lamotrigine.
Yes, the clinical implication is immense. While the primary disease state predisposes the child to psychiatric distress, specific pharmacological interventions can drastically exacerbate the exact symptoms we are trying to manage.
So the pediatric psychiatrist and neurologist must constantly calibrate that threshold between adequate seizure control and intolerable neurobehavioral toxicity.
It is a very delicate balancing act. And within the realm of epilepsy clinics, there is another highly complex presentation that requires an entirely different diagnostic framework. Psychogenic non-epileptic seizures, or PNES.
Yes, PNES.
Yeah.
These are events that visually mimic epileptic seizures, convulsions, altered consciousness, motor tics. But they are devoid of any abnormal cortical electrical discharges.
They are paroxysmal events with a strictly psychological or psychiatric origin. Yet they account for 1% to 9% of pediatric patients referred for continuous video EEG monitoring.
Almost 10% of cases. And the diagnostic difficulty is compounded by the fact that the clinical presentation morphs depending on the child's developmental stage. Older adolescents tend to present with dramatic motor features, right? Asynchronous thrashing, pelvic thrusting, side-to-side head movements.
Yes, but younger children present much more subtly. A 7-year-old with PNES might simply display sudden behavioral arrest, staring, and unresponsiveness.
Which, visually, is completely indistinguishable from a true electrical absence seizure or a focal impaired awareness seizure.
Exactly. Clinical observation alone is fundamentally inadequate. You cannot diagnose it just by looking at the child in the examination room.
So what's the gold standard for differentiation?
Capturing the habitual event on continuous video EEG. If the child is completely unresponsive and staring, but the concurrent EEG reveals entirely normal, organized awake background rhythms without any epileptiform discharges, you've confirmed PNES.
And we can utilize transient biochemical markers for convulsive events too, right? A true generalized tonic-clonic seizure induces massive muscle breakdown, which leads to a significant elevation in serum creatine phosphokinase, or CPK, peaking 8 to 16 hours post-event.
Yes. Additionally, true seizures often trigger a sharp spike in serum prolactin 10 to 20 minutes after the event. The absence of these biochemical surges following a major convulsive episode heavily supports a psychogenic etiology.
So once the diagnosis is confirmed, the physician faces arguably the most delicate conversation in pediatric neurology. How do you explain to a terrified parent and a confused child that the violent seizures they are experiencing aren't electrical without implying the child is simply faking or malingering?
It's incredibly difficult. The framing of this conversation dictates the entire therapeutic trajectory. The clinician must explicitly validate the reality of the events. They must state clearly that the child is not faking, that these physical symptoms are involuntary and deeply terrifying.
So you transition them to a biopsychosocial model. The brain is manifesting overwhelming, often unarticulated psychological distress, maybe severe anxiety, trauma, or familial dysfunction through somatic physical pathways.
Exactly. The body is sounding the alarm because the psychological coping mechanisms have failed. Once the family accepts that the symptoms are real but the root cause is psychological, you safely taper the ineffective antiepileptic medications.
And what's the frontline intervention then?
The intervention shifts entirely to multimodality cognitive behavioral therapy aimed at treating the underlying psychiatric trigger and teaching the child alternative somatic regulation techniques.
Which perfectly illustrates the core theme of this chapter, doesn't it? The inseparable nature of the mind and the physical brain. And this brings us to our fourth area where that connection is perhaps most violently disrupted: traumatic brain injury.
Yes.
We've looked at altered blueprints, faulty scaffolding, and electrical storms. Now we confront the unpredictable earthquake.
TBI in a developing child is a profoundly different mechanism than in an adult. The physical properties of the pediatric cranium and parenchyma dictate a truly unique pathophysiology.
Because children have thinner skulls and a significantly higher brain water content. So, while an adult in a motor vehicle accident might suffer a highly localized contusion or a focal epidural hematoma, a child subjected to the exact same rotational forces experiences massive, diffuse axonal injury and widespread cerebral edema.
The shear forces simply tear at the white matter tracts across the entire brain. However, there is still a distinct anatomical vulnerability. Pediatric TBI frequently results in disproportionate damage to the frontal white matter, the orbitofrontal regions, and the dorsolateral prefrontal cortex.
And the frontal lobes are the executive control center. They house the circuitry for impulse control, social judgment, and emotional regulation. When those tracts are sheared, we see the emergence of a specific, highly disruptive psychiatric syndrome that the DSM-5 classifies as personality change due to TBI.
It is a diagnosis applied to a staggering 40% of children who suffer a severe TBI. But I have to say, the nomenclature is somewhat misleading.
It sounds like a personality disorder.
Right, but it is not a personality disorder in the traditional axis to second sense. It is a profound, organically driven disorder of affective regulation.
The clinical presentation is explosive. We see intense affective instability, sudden aggressive outbursts, complete disinhibition, paranoia, and severe apathy. And the neuroimaging correlates perfectly with the behavior, doesn't it?
It does. If we look at children exhibiting personality change in the first year post-injury, the severity maps directly onto lesions in the superior frontal gyrus and the underlying frontal white matter. The dorsal prefrontal cortex is responsible for modulating and inhibiting the primal emotional impulses generated by the ventral limbic networks, specifically the amygdala.
So the TBI has literally severed the inhibitory brakes.
Yes, the affective dysregulation is a direct biological consequence of lost connectivity. The brakes are gone.
But the clinical reality of pediatric TBI is rarely that straightforward. When a psychiatrist is consulted for a child exhibiting severe behavioral dysregulation post-injury, they have to unravel a massive confounding variable, and that's the pre-injury baseline.
Which used to be completely ignored. Early literature focused strictly on new psychiatric disorders, meaning conditions that developed in children with absolutely no psychiatric history.
Which is mathematically flawed and clinically useless because it ignores the reality of who actually gets injured. The data shows that between 33% and 52% of children who sustain a TBI had a pre-existing psychiatric diagnosis.
The population is heavily skewed. Think about it. A child with severe untreated ADHD or oppositional defiant disorder is inherently more impulsive. They are more likely to engage in high-risk physical behaviors, and therefore statistically far more likely to fall from a significant height or dart into traffic.
So they are already a high-risk group.
Exactly. Therefore, the field adopted the concept of novel psychiatric disorders. This framework acknowledges that a child might have had pre-existing ADHD, suffered a severe TBI, and subsequently developed a novel, distinct disorder, like severe depression or psychotic symptoms.
And to navigate this immense diagnostic complexity, clinicians utilize Asarno's 6 pathways for psychiatric formulation in TBI. It is essentially a detective's flowchart for the psychiatrist. It forces them to rigorously categorize the etiology of every single symptom, preventing the lazy assumption that all post-injury behavior is just brain damage. Can you walk us through those pathways?
Oh, absolutely. The pathways are an elegant tool. Pathway 1 recognizes symptoms that simply predate the injury. The child had ADHD before the fall, and they still have ADHD after the fall. Pathway 2 describes a pre-injury vulnerability that is exacerbated by the trauma. So, say a child with mild baseline anxiety develops crippling panic attacks because the cognitive reserves they use to manage their anxiety have been depleted by the injury.
That makes sense. And pathway 3 is the direct biologic effect, right?
Yes. This is the personality change we just discussed, the severed frontal tracts directly causing disinhibition. But pathways 4 and 5 shift into secondary psychological reactions. Pathway 4 involves immediate secondary effects, such as post-traumatic stress disorder.
So the severe anxiety and hyperarousal are not caused by physical damage to the amygdala, but are a psychological reaction to the terrifying nature of the accident itself.
Exactly. And pathway 5 is perhaps the most tragic and commonly missed. These are long-term secondary effects.
Like frustration over new limits. Let's say a highly intelligent, academically driven child who suffers a TBI. Their processing speed is permanently reduced. 6 months post-injury, they begin exhibiting severe oppositional behavior in the classroom. The physical brain damage isn't causing the opposition. The profound psychological frustration and grief over their new cognitive limitations is driving the behavior.
Spot on. And treating that child with heavy antipsychotics for the behavior completely misses the underlying psychological grief. Finally, pathway 6 accounts for unrelated conditions. These are disorders that emerge post-injury strictly due to genetics or environment, such as the onset of schizophrenia in late adolescence or depression due to parental divorce.
Once the psychiatrist has accurately mapped the symptoms using Asarno's pathways, the treatment approach gets really fascinating. One might assume that severe biological brain damage requires primarily pharmacological intervention, but the data shows that psychosocial treatments are currently yielding some of the most robust, sustained improvements in pediatric TBI.
Yes, the breakthrough has been in web-based, family-centric protocols.
Okay.
Things like online family problem-solving therapy or FPST and counselor-assisted problem-solving.
So they don't just focus on the injured child.
No, they target the entire family unit. They train them in structured communication, crisis de-escalation, and behavioral regulation.
And what is truly remarkable is that the online modules demonstrated significant, measurable improvements in parent-rated adolescent behavior and executive function, while traditional in-person, face-to-face therapies often fail to show the same efficacy. Why is the digital delivery so superior in this specific population?
It likely comes down to cognitive load and accessibility. A family dealing with a severely brain-injured child is already overwhelmed. Forcing them to navigate traffic, sit in a waiting room, and process complex therapeutic instructions in a 50-minute clinical hour is just exhausting.
It's too much.
Exactly. Web-based modules allow the family to engage with the material at their own pace, rewatch modules when their cognitive resources are fresh, and immediately apply the strategies in their natural home environment. Furthermore, school restructuring is absolutely critical. Under the Individuals with Disabilities Education Act, special education interventions must be legally mandated to accommodate not just the academic deficits, but the profound emotional and behavioral dysregulation these children experience.
It requires a completely integrated ecosystem of care. We've covered an immense expanse of neuropsychiatry today. As we move into integration and key takeaways, let's synthesize the fundamental principles we've extracted from FASD, prematurity, epilepsy, and TBI. What are the universal truths governing the injured developing brain?
The primary takeaway is that psychiatric comorbidity is an inherent feature of pediatric neurology, not an incidental finding. When the structural or electrical integrity of the developing brain is compromised, psychiatric sequelae will follow in the vast majority of cases. Across these varied etiologies, the rates of psychiatric disorder consistently hover between 50% and 60%, with the notable exception of uncomplicated epilepsy resting at 27%.
And the most ubiquitous diagnostic label applied across all these distinct insults is ADHD. It appears in roughly 25% to 30% of these populations and spikes even higher in FASD.
But the critical clinical synthesis for you listening is recognizing that while the DSM-5 label is identical, the underlying neurobiological mechanisms are vastly different. The ADHD of a child with FASD is driven by an inability to set shift due to teratogenic structural rigidity.
The ADHD of a premature child is driven by an inability to sustain attention due to necrotic white matter tracts.
And the ADHD of a child with TBI might be driven by frontal lobe shearing. The presentation is a shared final common pathway, but the pharmacological and behavioral interventions must be tailored to the specific mechanical failure.
We also see highly specific etiological links with autism. ASD is heavily correlated with the altered white matter development of prematurity, presenting with profound pragmatic communication deficits. Conversely, true ASD is rarely documented as a novel disorder emerging after an acquired childhood TBI.
And crucially, the clinical assessments themselves must adapt to this reality. The textbook highlights a vital clinical pearl. Standardized, structured psychiatric interviews are infinitely more sensitive and reliable than parent-completed behavior checklists in brain-injured populations.
The shifting goalposts phenomenon.
Exactly. Parents naturally and unconsciously accommodate to the profound limitations of their brain-injured child. A mother whose 10-year-old functions cognitively at a 4-year-old level will evaluate their behavior based on that adjusted expectation. They might not report severe emotional outbursts on a checklist because it has just become their daily baseline.
So a structured clinical interview conducted by a psychiatrist recalibrates the assessment back to normative developmental expectations, revealing the true depth of the pathology.
Yes, you are treating the family's adaptation to the trauma just as much as the trauma itself.
Which leads to a final, truly provocative question regarding the fundamental nature of child neuropsychiatry. We have discussed the astonishing plasticity of the developing brain, its ability to build detours around necrotic watershed areas, its desperate attempts to rewire around teratogenic blueprints and sheared frontal lobes.
This is remarkably resilient.
But if the brain is continually executing its own complex biological adaptations to survive early insults, at what point does that adaptation become a psychiatric pathology? When we prescribe heavy psychotropics to suppress the externalizing behaviors of a child with severe FASD or TBI, are we genuinely repairing a dysfunction? Or are we, in fact, chemically dismantling the brain's absolute best, albeit clumsy, attempt to survive and function within the confines of its irreparably altered architecture?
It's a profound ethical dilemma. It forces the clinician to question whether our treatments are designed to optimize the child's unique neurological potential or merely to chemically enforce societal expectations of compliance upon a brain that is fundamentally built differently.
Something for you to mull over. To reinforce the specific mechanisms and diagnostic criteria we've synthesized today, We will conclude with 6 single best answer questions. Listen closely, consider the underlying neurobiology, and review the source material if necessary. Let's do it.
Question 1. In a very low birth weight infant, which specific cellular structure is highly susceptible to oxidative stress, hypoxia, and ischemia, directly initiating the destructive cycle that leads to periventricular leukomalacia, or PVL? Take a second to think about it.
The answer is pre-oligodendrocytes. Those are the immature glial cells responsible for future myelination.
Question 2. A 10-year-old child with a documented history of severe fetal alcohol spectrum disorder presents with profound academic and behavioral issues. Which specific cognitive profile strongly differentiates this child's presentation from idiopathic ADHD?
Well, the answer is severe deficits in shifting between attentional sets and encoding new information, combined with an arrested developmental trajectory in socialization and communication skills.
Brilliant. Question 3. A 7-year-old patient is referred to neurology for sudden, recurrent episodes of behavioral arrest and unresponsiveness. Continuous video EEG monitoring captures an event, revealing completely normal, organized background rhythms without epileptiform discharges. What is the definitive diagnosis and what is the primary indicated treatment?
The diagnosis is psychogenic non-epileptic seizures, or PNES, and the frontline treatment is multimodality cognitive behavioral therapy aimed at the underlying psychological distress.
Question 4. Utilizing SRNOS pathways for psychiatric formulation, if an adolescent develops severe treatment-resistant depression a year after a severe TBI, solely because they are grieving their inability to return to their pre-injury athletic scholarship level, which diagnostic pathway does this represent?
That represents Pathway 5, a long-term secondary psychological effect of the TBI, unrelated to direct neurogenic damage.
Question 5. Following a high-speed motor vehicle accident resulting in a severe traumatic brain injury, a previously placid child develops profound affective instability, sudden aggressive outbursts, and complete disinhibition. This presentation of personality change due to TBI is neuroanatomically most closely associated with shearing lesions in which specific region?
That would be the superior frontal gyrus and the underlying frontal white matter tracts.
And the final question, question 6. When evaluating for psychiatric comorbidities in pediatric populations with acquired or developmental brain injuries, what is the primary clinical rationale for prioritizing standardized psychiatric interviews over parent-completed behavior rating scales?
The rationale is that parents frequently accommodate to the child's neurological limitations, unconsciously shifting their baseline expectations and subsequently underreporting significant psychiatric symptoms on standardized checklists.
Spot on.
Here are the details of this episode.
Psychiatric aspects of child neurology. Byline: the developing brain where growth, vulnerability, and adaptation unfold together.